Well, for the welcome to country, it's actually going to be an acknowledgement of country. And I'd like to introduce a colleague and good friend, Boe Rambaldini. Boe is the Bunjalung elder from the far north coast and also director of the Poche Centre for Indigenous Health at this university. It's one of 5 Poche Centres nationwide. And Boe, I'm very pleased and honoured that you're going to give the acknowledgement of country.
Thanks, Ben.
Thanks, Boe.
Hello, everybody. It's with great respect and a deep honour to actually give this acknowledgement to country on the traditional lands and sacred lands of the Gadigal people of the Eora Nation that we're holding a special event on. Now, it wasn't been that far from here where the end of a healthy and a strong nation of Gadigal people was attacked and their whole health changed completely. And this affected right across Aboriginal Australia, and as probably most of you know, the rest is history. My people have the worst health outcomes than any other group in this country, and they're the concerns that really shine on us at the university and at the Poche Centre. Well, and we now need to shine a light on the picture regarding the health of Aboriginal people. When we do things, we need to know in this country also for Indigenous people internationally as well. And the past holds some very important information and answers for us to try and bring about some changes because people are too frightened to go back there. At the Poche Centre, I had a couple of doctors come in there and offered to do some volunteer work for us once, because that's what we do to improve the health of Aboriginal people. And they told me we should start now, draw a line here and let's go forward and improve the health of my people. I said to them, I said, when you get a patient walking into your surgery, I said, what's the first thing you say to them apart from their name? You want to know if they've got a history in diabetes, you want to know if they've got a history in heart disease. And I'll tell you why you want to know that. You want to know that so you can develop a plan and make them well into the future. So you want to know what happened back there so you can make them well into the future. And they sort of got the picture then that we need to look at the past to understand the past. And this country hasn't got a very good past when it comes to Aboriginal people. Heart disease is a substantial problem for my people. As you know, many of my people have chronic heart disease or experience heart attacks, and this is a common reason for people to be admitted to hospital. Heart disease is the leading cause of death in both Aboriginal and non-Aboriginal Indigenous Australians. Sadly, many Aboriginal people who die of heart disease do so at a very young age, some of them. So it's a relatively young age that they're passing away, and we all know that the risk factors are in regards to what causes these things: smoking, high cholesterol, blood pressure, diabetes, inactive, overweight, and so forth. All of these factors can be traced back to those colonisation days that have impacted on our country over 230 years ago. We are not closing the gap. The gap is widening, and a lot of work needs to go in it to try and do what we can to close the gap between Aboriginal and non-Aboriginal people in this country. It is important that all people who have experienced a heart attack or a chronic disease receive equal good clinical care. Currently there are some aspects of best practices in regards to chronic health disease care that my people are less likely to receive that quality of care than other Australians. So we need to do a lot more in that area to improve the situation. The HRI and the Poche Centre for Indigenous Health are working closely together to try to shine a light on these important issues. I want to acknowledge my dear friend and champion of my people, Dr. Ben Freedman. We've known each other now for a few years since I've been here, and we've been involved in some collaborations both nationally and internationally. And he has placed these issues on the national stage and the international stage. The Poche Centre was set up by Greg and Kay Poche, and the co-founder of the Poche Centre was Reg Richardson for setting up, and I really wouldn't be able to do the things that we are doing to improve the quality of health and get Aboriginal people to take their rightful place in society and lift the status of their health without their generous donation. So we all have, so in all we do in this area, please keep in mind my people, because like I said, we've got the worst health outcomes in any other group, and we certainly can't do this on our own. Thank you.
Thank you very much, Boe. All right, much appreciated, Boe, and it's my pleasure to welcome you all to the fourth public lecture here at the Charles Perkins Centre. This was set up as part of our annual dinner. In fact, when Bob, you were part of the panel that was reviewing the Heart Research Institute, we had John Cook as our inaugural speaker. And it gives me an absolute pleasure to introduce Bob to you this evening. Bob said to me, just keep it short, don't say much. But that wouldn't be appropriate. I mean, Bob is a towering figure in this state, as you know, in cardiovascular research. When you think about New South Wales and cardiovascular research, one of the first names that comes to mind is Bob Graham. Bob really had amazing training, trained with 2 Nobel Battle laureates in the United States, both in Texas and in Boston. Both not satisfied with Harvard, had to be Harvard and MIT. Worked there for 17 years, became chair of a department, was absolutely stellar scientist. And, you know, I've known Bob really since he came back to Australia, and I'd describe Bob as a scientist. He's at the absolute top of the tree when it comes to scientific quality and understands what science is all about. Bob's a remarkable guy because there's very few people you can introduce that set up an institute as made as successful as the Vic Australians Bob had over the last 25 years. And really, Bob and his team have set the standard for research in New South Wales. There's no question about that, Bob. And he's immensely proud of his institute and what he's achieved. But most importantly, he's a very powerful advocate for cardiovascular research within New South Wales, but within the country and even internationally. And he's going to talk to us tonight about cardiovascular disease in women, an underappreciated topic. And Bob, you're going to talk to us in 3 chapters. So we're delighted to welcome you here to the CBC.
Well, thanks very much. It's really a great honour to be invited to give this lecture amongst so many great friends and so many great scientists here in this campus, including yourself, Sean. So thank you very much. And also want to thank Ben, because for some reason when I was invited to give this lecture, it didn't go past my frontal lobe that this is a public lecture, and so I prepared this really dense scientific lecture, and Ben reminded me it was public, so I've had to rework the lecture, so apologies for that. If you don't mind, I'm going to get comfortable because it's sort of a little warm here, and I think better when I'm comfortable. So look, what I thought I'd do, Boe, is talk about another underprivileged group of people who are not well treated, and that's women. And women and heart disease is a topic that's only recently come to the fore, and I think needs a lot of work because we've got a long way to go, and a lot of us men are guilty of not looking after women as well as they should with heart disease. So before I go on, I want to dedicate this lecture actually to all those ladies who suffer from diseases that particularly, cardiovascular diseases particularly affect women. And we've got into this only recently, and we look into a disease I'm going to talk about, which is called spontaneous coronary artery dissection, or SCAD. And these are a wonderful group of people to work with, and some of them have been instrumental, particularly Pamela McKenzie out in Busselton, who we run a Q&A site at my institute, which I answer questions for people about heart disease. And she contacted me and said she just had an episode of SCAD. She actually had a very bad episode of SCAD, which involved her left main coronary artery. She almost died, and it's lucky she survived. But I then did a bit of research and found out there wasn't much going on in Australia, and we started this research program, and that's how I've got into this area. Another really illustrious person is Sarah here. Sarah's just started a website, which just launched today actually, So you can go to, that's www.scadresearch.com.au, and which is for people who've, it's a support group for people who've got SCAD. So look, what I wanted to do is tell you about cardiovascular disease in women, particularly those diseases that are specific, pretty specific to women. And I want to tell you about 3 different diseases, and hence the title is a story in 3 chapters. And as a prologue, I just want to tell you a little about the 6 differences in cardiovascular disease. Then I'll tell you a bit about spontaneous coronary artery dissection. And then I'll tell you about a related disease called fibromuscular dysplasia. And finally, another disease is related called Takotsubo's cardiomyopathy or broken heart syndrome. And then finally, I'll wrap up and go over what I've just told you. So our typical image in the cardiovascular community of cardiovascular disease is a man with poor lifestyle habits. Now, it's true that men with poor lifestyle habits are more prone to get cardiovascular disease, but so are women. In terms of women's health issue, what people think of as breast cancer. And what they don't realise is that 3 times more women will die of heart disease than breast cancer. So it's very much underappreciated that cardiovascular disease is a killer of women as well as men. Some of the reason for why we think of men as being more prone to heart disease comes from this graph, which shows you mortality with age. And you can see that at all ages, men do have a higher mortality than women, although towards the latter years of life, the curves almost start to converge. So historically, cardiovascular disease is seen as a disease of men. However, women fare worse than men do when they do get cardiovascular disease, and this shows you the 5-year incidence of heart failure after the first myocardial infarction by age, sex and race, and this comes from the United States. And it shows you that white women compared to white men do worse, and black women compared to black men do worse. And it's only in the latter years where that's it's changed a little bit. But if you now look also at the 5-year incidence of death after myocardial infarction by age, sex and race, and you can see again in all ages this time, white women do worse than white men, black women do worse than black men at all ages all the way through. And that's not just peculiar to the United States. If you look here in New South Wales, you can see here that the outcomes for women after a heart attack are much worse than men. And death within 1 year in 2004 used to be up around 25%. It's come down nicely over time, but still continues to be very much higher than in men. So women certainly have their share of cardiovascular disease, and as I said, it's underappreciated. There are, of course, traditional risk factors which affect both men and women, and they include, as Boe pointed out already, age, smoking, cholesterol, diabetes, high blood pressure, a family history of cardiovascular disease. But there are some female-specific risk factors which a lot of people don't think of. Early menarche, early menopause, hysterectomy, early age at first birth, a history of miscarriage, a history of stillbirth, gestational diabetes and preeclampsia are all risk factors for subsequent cardiovascular disease. And there's a female disadvantage, and by that I mean women, and this is very sad to say actually, and is a bad reflection on us as male doctors, women are less likely to receive statins for primary and secondary prevention. They're less likely to receive anticoagulants for atrial fibrillation. They're less likely to receive percutaneous interventions for coronary heart disease, less likely to receive left ventricular assist devices or LVADs, or a heart transplant if they've got advanced heart failure. And to top it off, I think this is really an indictment of us as male doctors, is that female patients of male cardiologists have worse outcomes with no such gender difference for female cardiologists. So we as male doctors have a lot to learn and a lot to correct. But what I want to reflect on today is not so much these sex differences, but to speak about 3 specific disorders that predominantly affect women. So let me start with the first chapter, which is spontaneous coronary artery dissection. This is a disease of the coronary arteries that supply the blood to the heart itself. And it presents like a heart attack, or what we call an acute coronary syndrome. And it's due to a bleed into the wall of one of the coronary arteries, leading to the accumulation of blood. And that then bulges into the cavity, into the lumen, the true lumen of the blood vessel, and it obstructs the flow of blood to the heart itself. And so you get a heart attack, or the patient gets a bad arrhythmia, or they can die. Predominantly affects women. 92 to 98% of cases are women, and they're relatively young. They're generally not overweight, and they have a low incidence of traditional risk factors. And that's a problem, because when these people present, nobody thinks that they're going to have heart trouble. And they think they might have dyspepsia, or they have pneumonia or some other problem, but they don't think they have heart disease. And they don't do tests to try and diagnose a heart attack in these women. And some of them, and I've had many cases, they get sent home that they're just neurotic and they shouldn't worry about it. And I think some of them probably die at home, which is very sad. As I said, it's underdiagnosed because of the way it presents and because a diagnostic angiogram is not performed or a troponin level is not obtained. Less of a problem here in Australia, where we do a troponin level if you have a sore toe, but in Europe they don't do troponin levels as readily, and often they are missed. Now recognised to be the cause of 2 to 4% of all cases of acute coronary syndrome, and 24 to 36% of heart attacks in women aged less than 50, and it's the commonest cause of a heart attack associated with pregnancy. So it can generally, the peak age is, as I said, 45 to 52, but it can be occur in association with pregnancy. Generally, the peak time is in the first week after a woman has given birth to a baby, but it can even occur during pregnancy, although that's much less common. More common in women who are multiparous, who are undergoing IVF treatment, or have already had several children. And the disease is much more severe than in the other group of women, and they often go on to get severe heart failure and complications. So why does this actually occur? What is the pathophysiology? As I mentioned to you, it's a bleed into the artery wall, the artery that supplies the heart muscle itself. And just for those just to remind you of what the blood vessels look like. So you've got here normal blood vessel here, and there's an outer layer here called the adventitia, which is connective tissue. You've got a middle layer, which is called the media, which consists mainly of smooth muscle cells. And you've got an inner layer here where the blood flows, which is called the intima, or made up of flat endothelial cells. So what happens here in SCAD is 2 different ways that you can get this bleed into the wall. One is due to a dissection, and that's where the name comes from, spontaneous coronary artery dissection, due to a dissection in the intima here, and that causes blood to track down into the wall and to cause a false lumen here, or a false cavity, compared to the true lumen, and that then bulges and pushes, and I'll show you in a moment an extreme case of that where someone died. Or the other reason can be that you can actually get an intramural hematoma due to the fact that you have these small blood vessels called vasa vasorum, which actually provide blood to the vessel itself. And they can rupture and cause a bleed in intramural hematoma, or a bleed in the wall of the artery, and that also can cause bulge into the true lumen of the blood vessel and obstruct flow. You can see here that this one here, where you have a tear, is called a type 1 SCAD, and that's responsible for about 30% of cases. And the other type is responsible as 2 different varieties of these, which affect either a long segment of artery or a shorter segment, called type 2 or 3, and they're responsible for 70% of cases. Whether these ones actually occur because the intima tears initially, and then you get blood into the wall, or whether you get blood in the wall first and then it ruptures into the cavity itself is not clear. So either possibility can occur. What's curious about this is we continue to manage these like regular plaque-induced coronary artery disease, or what we call atheromatous coronary artery disease. And we put these people on anticoagulants, and my thesis here is that we shouldn't be treating certainly these 70% that have type 2 or 3 with anticoagulants, because you'll only make the bleed worse. Why do we treat a bleeding disorder with an anticoagulant? And it's just a hangover from what we do for atherosclerotic coronary artery disease. This type here, you can imagine you might get some thrombus or clot formation here at where the gap is there, and there may be some rationale for anticoagulants, but I don't think there's any rationale for using anticoagulants in these patients, but not everyone agrees with me. So this just shows you a very severe case of SCAD, where you've got this huge false lumen here filled with clot, and it's pushed the wall of the artery right up against the other, and you can only just see the outline of the true lumen here, which has been virtually completely obstructed. You can imagine there's not going to get any blood flow through that. This patient went on to die from an episode of spontaneous coronary artery dissection. This shows you the false lumen here filled with clot, and again, very hard to see. This is where the true lumen was, and you can imagine that was caused major problems. So the precipitating factors for this disorder is an increase in shear stress, probably, certainly the ones that cause an intimal tear, associated with an increase in pressure in the chest, or to a catecholamine surge. That's an increase in adrenaline that you might get, for example, when you're under stress or under duress. There are a number of precipitating stressors, and these include intense exercise, particularly isometric exercise, where you raise your diastolic pressure, and that can precipitate this. Intense Valsalva maneuver. In fact, the very first woman described in 1931, a lady in England, she actually sat up in bed and she vomited, she'd been sick, she had some gastric problems and retched, and she died in her husband's arms and left 3 children. She was only 42 years of age. Vasoconstrictor drugs can do it, especially those, for example, used for treating migraine, which cause constriction of blood vessels, and the triptan drugs are drugs that probably are a no-no when people have had an episode of SCAD, because you get a recurrence. Bereavement or major stress is really one of the most prominent preceding features of an episode of spontaneous coronary artery dissection. It has to be usually pretty major stress, such as loss of a loved one, going through a divorce, or a major family upheaval. Drug abuse, particularly cocaine, can cause this, and high-dose hormonal therapy, as I mentioned to you, the ones associated with pregnancy, certainly have worse problems, and that's often they get high doses of drugs like beta-HCG to cause ovulation and to allow them to become pregnant. And coronary artery spasms certainly can be associated and go on to have an episode of SCAD. The presentation is very much like a regular heart attack. So they present with chest pain, radiating down the arm, with nausea or vomiting, radiation to the neck, or they can get sweatiness or breathlessness, back pain. But the most common one is chest pain radiating down the arm, just like a regular heart attack. So the management, the important thing about the management of these is that you don't go in and do a percutaneous coronary intervention. That is where you put a balloon into the artery, what you do for a plaque-induced heart attack, and you open up the artery by pumping up the balloon, and then you may put a stent in. And the reason you don't want to do that is they don't do particularly well at all. They don't do nearly as well as an atheromatous lesion, and you can extend the dissection. And some of these people get very long dissections. There's been many cases reported of the entire LAD, left anterior descending, the major artery supplying the front of the left ventricle, being dissected all the way from its origin to the tip. So the guide wire is the problem. And while we sometimes use fancy tests to look at what the problem is, like OCT or intravascular ultrasound, you've got to be very careful doing that, because the catheters are quite large, and you have to use a guide wire, and you can very easily cause a propagation of that dissection, which can be disastrous. Coronary artery bypass grafting is really reserved for those people with resistant pain or major complications. And long-term management, there have been no randomized controlled trials, and there's observational data suggested good blood pressure control and beta blockers, the treatment of choice in these people. But as I said, there's been no randomized control of different therapies in this group of patients. Outcomes are generally favourable if they get into hospital, with less than 5% mortality, although they do have a high incidence of major adverse cardiovascular events in up to 30% of patients. The interesting thing about the lesions is that if you do the angiogram and look at their blood vessels, apart from the dissection, the rest of their arterial tree looks very normal. You may in some cases see tortuosity of the vessels, but in most cases they look entirely normal. And the interesting thing is that the lesion heals. It heals within 35 days, virtually all of them have completely healed, but they can recur in about 20 to 30% of cases. And there's been one reported case where a woman had 5 episodes of SCAD, all involving different parts of the coronary arterial tree, and all of them healing before the next episode occurred, and they never occur in the same place. And presumably, although they look normal afterwards, there may be some fibrosis there that reduces the occurrence from occurring at the same place again in the future, and so they dissect a different part of the arterial tree. There is also a high burden of linked mortalities, and I want to stress this here, and I don't think, I get called all the time by these ladies who've had this, and a lot of the doctors don't give the patients the time they need to tell them about their problems. There's a lot of anxiety associated with this. You can imagine if it's associated with pregnancy and they have a young baby, they don't know whether they can lift the baby or not. They don't know if they happen to have a SCAD episode associated with exercise, whether they can continue their exercise. So these are all, and the fact that they can recur and they live in fear that they're going to get another recurrence. There's a great deal of anxiety, and in fact, in one study, it's been reported that up to 30% of women had true post-traumatic stress disorder afterwards. So they really need to be going to cardiac rehabilitation, and the doctors need to be spending time with them and trying to help them through what is a very anxiety-provoked time. So the pathophysiology is not well understood at all. There are a few clues that we have. They can, as I mentioned, can occur in association with pregnancy, peripartum, especially when the hormones are falling in that first week after pregnancy. The ones that occur in the women of the major age, around 45, 52, generally occur around the time of menopause, again, a time when the hormones are changing. It can be associated with other vasculopathies, that is, other vascular diseases such as migraine, not uncommonly, fibromuscular dysplasia, which I'll talk about in a moment, but it's infrequently associated with other known inherited collagen vascular diseases such as Marfan syndrome or Ehlers-Danlos syndrome. So you only find those in a very small percentage of people with spontaneous coronary artery dissection. And it can occur in association with intense physical or emotional stress, a time when one could imagine you have a big catecholamine surge, which might cause increase in shear stress and may explain why you get a tear in the coronary artery. There is also a genetic, almost definitely a genetic predisposition, and familial clustering of cases has been described. And we've now accumulated some 240 cases around Australia, thanks to the women with SCAD, and particularly to Pamela Mackenzie, who started a Facebook site, and more recently Sarah Ford, who's now, as I mentioned, started a website. So we've been able to get these 240 cases, and amongst those we've now got 12 families with more than one family member being affected. So it's sister, mother, daughter, auntie, niece, etc. And to show you one of these, this is one of our families here. This is a family where you've got 3 cousins, all having had an episode of SCAD. This is how old they are now. This is how old they were. They were 37, this woman. This one here was 51, she's now 53. And this lady here was 40 when she had her episode of SCAD, she's now 42. And as I mentioned to you, we've now also got a family where we've got monozygotic twins, that is identical twins, where both twins have had an episode of SCAD. And we've got another family with identical twins where only one so far has had an episode of SCAD. And you can imagine the other twin would, I would imagine, be very worried that she's going to have an episode of spontaneous coronary artery dissection. The hypothesis, we believe, given these pathophysiological clues, is that SCAD really involves what we call a gene-environment interaction. That is, you have a genetic predisposition which enhances your susceptibility of the blood vessel wall to rupture, and that's then acted upon by an environmental cue, such as an increase in shear stress, which then together trigger the dissection. In addition, we believe from our studies so far that SCAD is almost definitely what we call a multigenic disorder. It probably involves several genes, some of which may impair the integrity of the intima, that is the endothelial cells and the underlying basement membrane that they put down, and they would most likely give rise to the type 1 SCAD, the ones that have a tear of the intima. Or they may have a genetic predisposition which impairs the integrity of the media, and that, of course, will involve the smooth muscle cells, the internal elastic lamina associated with that, or the adventitia, which is where the vasa vasorum run, and where you have an extracellular matrix. How do we start to dissect the pathophysiology of SCAD? As I mentioned, we've now got a cohort of 280 cases. Almost all, I must say, are Caucasians, and that has been peculiar in all the SCAD studies around the world, that there's a preponderance of Caucasians, but that may be selection bias in that most of those clinics probably see Caucasians more readily than they see other ethnic groups. And I mentioned, of course, the familial cases that we already have. We've now undertaken so far genomic studies, and in collaboration with groups at the Mayo Clinic, a group in Paris and a group in the University of Leicester, we've been able to identify the first genomic variant. And by a variant, for those who aren't in genomics, what I mean is that we have 6 billion base pairs that make up a whole genome, and some changes in the material, the base pairs that make up our genome, can be quite benign. It's a little like if you think of, in America they spell colour C-O-L-O-R, and in Australia we spell it C-O-L-O-U-R. And that difference in the spelling doesn't make any difference at all. We still understand the word colour. But sometimes if you have a variant that can cause disease, that can be very different. So there you might think about something like desert, D-E-S-S-E-R-T, or desert, D-E-S-E-R-T. There, one single change can make a big difference in what you have. And what we've found is that there's a variant, we don't know yet whether it's the colour or desert type, but it's certainly a variant that very strongly is associated with this disorder. And you can see here that very powerful statistics here. It's got an odds ratio of 1.67. So that the people who have a certain variant in this gene here, this gene called factor R1, then it's very highly significant, 6.7, 6 by 10 to the 23rd, there's a very high chance that this is a real association with the disease. It's not a particularly useful one, though, I must add, because 60% of the population have this variant, but 70% of women who have SCAD have it. So it causes accounts for about an extra 10% over and above the normal. So there's a lot of normals who have this variant and they don't get SCAD. But in the cases who do get SCAD, you find that 70% of them have this variant. We've also now completed whole genome sequencing of DNA of about 107 of our SCAD patients, including many of the familial SCAD cases. And what this has shown to us is this is going to turn out, this is going to be somewhat of a nightmare to try and sort this out, and we're trying to do that. And we have not been able to, with this data that we have available already, we have not been able to confirm a number of genetic variants, that is colour changes or desert changes, that have been suggested. So there are 3 different genes here. I won't go into in detail, F11R, talin here, and this ribosomal maturation factor. And we don't see an excess of this variant in the cases over what occurs in those in the controls. So you can see here, there's no difference here, there's no significant differences in the number of cases that have the variant compared to the number in controls. And the controls here, I must mention, are the Medical Genome Reference Bank. They are 1,127 people over the age of 70 who are healthy with no cardiovascular disease. So they're a very powerful control group. We've also not been able to see any enrichment of variants in people who have got underlying connective tissue vascular disorders in which SCAD has been reported to also occur. So these include things like Ehlers-Danlos syndrome, Marfan syndrome, this is fibrillin gene, the nail patella syndrome, these are rare syndromes, Polycystic kidney disease has also been described or patients with SCAD have been described in people with polycystic kidney disease, and also Lowe's-Dietz syndrome, which is again a rare syndrome. There's 3 different genes have been implicated, and again we've not been able to find any significant difference between the cases and controls, suggesting that none of these variants that have been reported to date are in fact correct as a cause underlying SCAD. So we have a lot of work to do to now try, and we are continuing to fish through our data and to do more whole genome sequencing to see if we can find variants that are peculiar. We have got some that look very promising, but they are peculiar to some families and they don't occur in all of them. So that's why I think this is going to be a multigenic disease. The other way we can try and dissect the pathophysiology of SCAD is, of course, you can't get a biopsy of a coronary artery. People don't like it if you biopsy their coronary arteries because they need them. So the only way to get around that I can think of is to make blood vessel cells. And the way you do this is to take a mature cell like a white blood cell or a fibroblast, which is a skin cell, and you can transform that to go back to being completely immature. A completely immature cell, so immature that it can make an entire new organism, and that's been done, at least in terms of mice. So we can, this is a wonderful procedure that was actually discovered by a Japanese worker, Yamanaka, for which he got the Nobel Prize, quite rightly, back in 2012. And so we've started to do that, and this shows you some, what we call, these are now called, the ones that are immature, called induced pluripotent stem cells. And you can see here that this shows you the cells growing nicely, and this shows you the expression of one of these genes that pushes the cells back from being mature into being completely immature. And you can see here that they are indeed able, what we call pluripotent. They can make any tissue in the body, any of the 3 major tissues in the body, which are the ectoderm, the mesoderm, or the endoderm. And these are markers showing you here lighting up for each of these different tissue types. So we have indeed made induced pluripotent stem cells. In fact, we've reported on the first one already. And we've now been able to take these cells and differentiate them. And this is with help of Jenny Gamble here at the University of Sydney, and make them into endothelial cells. This shows you them being mature, differentiated into endothelial cells at day 6, day 14. And this shows you double positive cells for 2 markers of endothelial cells, CD34 and CD31. And we take the double positive cells, and if you grow them in culture, they do what endothelial cells do. They make tubes, which is a nascent blood vessel. And they make the tubes, and they also show characteristics of endothelial cells. That is, they have phagocytic properties. They take up acetylated LDL. So they are, in fact, bona fide endothelial cells. And now we're using them to try and find a change in these cells that is in the patients that may not be in the controls, and then we can potentially use them to find out what genes are different, and hopefully in the future we may be able to use them to screen drugs to see whether we can change the difference between the patients and the normals, and that's called disease in a dish drug screening. So we've actually got the disease there from the characterized in the cells that come from the patient. And hopefully if we can find a phenotype, we'll be able to do such tests and maybe be able to come up with a treatment that changes the difference between the cases and the controls. So let me move on to chapter 2, which is a related disease called fibromuscular dysplasia. It's predominantly a disease of women. Again, over 90% of women are affected, with a mean age at diagnosis of 52, but with a large spread from 5 to 83 has been reported. And again, there's familial clustering of fibromuscular dysplasia, but that's low, as it is in SCAD. In about 10% of cases, you find familial clustering. Also, like SCAD, it doesn't involve the build-up of a plaque like a traditional coronary artery disease. It's actually non-atheromatous, non-inflammatory type of vascular disease. It manifests as arterial narrowings or stenoses, also very tortuous, snake-like blood vessels, aneurysms or dissections causing high blood pressure or infarction, especially in the kidney, because it predominantly affects the kidney arteries as opposed to the coronary arteries. And it can cause migraines, transient ischemic attacks or strokes if it involves the cervical arteries, the carotid and the vertebral arteries. There are two types. The uncommon type, which affects about 10% of people, is the focal type, which causes a tubular type of narrowing, generally fairly short, and it's due to intimal fibroplasia or rarely medial hyperplasia. So that's a proliferation of the smooth muscle cells, or a fibrous change in the lining cells, the intima. The more common type are multifocal. They're common. They have alternating stenoses caused by fibromuscular ridges, and that's due to proliferation of a particular type of cell. It's a smooth muscle cell that's been converted into a fibrous-like cell or fibroblast-like cell, and they're called myofibroblasts, and they proliferate, and then there's dilatation as well, and that's due to the fact that you've got death of some of the smooth muscle cells. You get alternation, proliferation of smooth muscle cells and myofibroblasts alternating with death of the smooth muscle cells, giving you this classic beaded appearance, and that's shown here very, very nicely. I think it's quite clear to see this beaded appearance in the kidney artery here, and this shows you in the carotid artery here the beaded appearance. As I said, it mainly affects the kidney arteries in about 80% of cases, and the extracranial carotids in 74% of cases. Less commonly affects the mesenteric arteries, the iliac arteries, and it's also been suggested it can occur in the coronary arteries, although that's still debated. The pathophysiology remains unclear. Overall, there's a disorganization of the medial layer, and that's evident histologically, with a loss of smooth muscle cells, as I just mentioned to you. A high proportion of middle-aged women suggests there may be a hormonal component associated with vascular remodeling, which may underlie the development of this. In dogs, you can actually get a similar lesion in the kidney by just pulling on the kidney. It's more common on the right side than the left, and it's thought that the right kidney underlies the liver, and so it has a longer renal artery, and there's traction on the artery, and it's that traction that incites that inflammatory effect and causes the overgrowth of the myofibroblasts. But it's still not clear. The pathophysiology is far from clear. Some have suggested excessive pulsatility can cause microtraumas, and that can give rise to these changes. And some have suggested it may be due to occlusion of those vasa vasorum, the little blood vessels that supply blood to the major blood vessel itself. And indeed, a very interesting study was performed a long time ago now where they occluded the vasa vasorum. They put a thrombin gelatin mixture into the blood vessel, let it sit there for a while, and that occluded all the vasa vasorum. And you can't see any here, but you can see the normal blood vessel. They then used India ink to outline all the vasa vasorum. They're all present there, and they're gone here. And then when they looked 200 days after that, using electron microscopy at the blood vessel, you can see this typical myofibroblast appearance of the cells here in the vessel wall. So this is a model. It's far from proven that that's the cause of it. Associations, as I mentioned, extracoronary fibromuscular disease can occur very commonly in people who have a spontaneous coronary artery dissection. And depending on what study you look at, up to 86% of people who have an episode of spontaneous coronary artery dissection also have fibromuscular dysplasia in non-coronary vessels, either in the kidney or in the cervical arteries. And you can see here this gene that we found to be so highly associated with SCAD up here is also highly associated with fibromuscular dysplasia. If you have the one variant, the desert variant, so if you have the one variant, you get all these diseases here. So these are called alleles. If you spell desert D-E-S-S-E-R-T, so the allele is much more common in these people with SCAD, fibromuscular dysplasia, cervical artery dissection, migraine. Whereas if you have the other spelling, then you're much more likely to get heart attacks, coronary artery disease, coronary artery stenosis severity is more severe, and coronary artery calcification. And in fact, if you have the variety that's found in SCAD, they're actually protected from atherosclerosis coronary artery disease. So it's a very curious allele that's not found very commonly at all in genomic medicine, to have one allele that causes one lot of diseases and the different allele that causes the other. And we've obviously got a lot to learn about that. Now, Jason Kovacic, who did his PhD with me, has been in the States for a long time, and he's been doing studies on fibromuscular dysplasia. I don't want to spend a long time on this, but he's trying to develop a test to diagnose it because it often is undiagnosed for many years. So he's looked at the blood of these people and he's found certain substances in blood doing what's called a metabolomic study, and he's looked here at various proteins, and he's found that some proteins are very enriched in people with fibromuscular dysplasia, and also some lipids, some fats in the blood are highly enriched. And from that, he's been able to use an artificial intelligence program to try and use these as predictors of who might have fibromuscular dysplasia. And this is just a fancy way of looking at how good your test is once you have these various predictors. This is called a receiver operating curve. So if you have an absolutely perfect test, it would look like this. It would be hyperbolic. If you have a test that's no good at all, it looks like the straight line down here. That gives you a value, a C value of 0.5, and he can see his is up at 0.61, and if he combines proteins and lipids, he gets up to 0.73. So it's not optimal yet, but he's getting to a point where he's working on a test that may be able to diagnose fibromuscular dysplasia. So let me go on to the last chapter, which is Takotsubo syndrome. This is where people present with an acute heart dysfunction, often with an acute coronary syndrome, and it's generally does pretty well. They're transient. They last for about 21 days. Also, again, more common in women. And the reason it's called Takotsubo is it comes from the Japanese word for an octopus trap, which is shown here, and it's got a narrow neck. The octopus crawls in, and I'm not sure why it can't just crawl back out again, but I guess it feels happy and now it lives there. And the reason it's called that is when the Japanese did an echocardiogram on these patients, what they see is this big bulging left ventricle here, and it's bulging because the apex, the bottom part of the ventricle, is not contracting properly, and so it balloons out. And in addition, you've got the top part, the base of the heart, contracting very vigorously. So you've got this narrow neck, if you like, here due to the hypercontractile base, and this big bulge due to the akinetic or not moving apex of the heart. And it's very characteristic. You can actually get it the other way around, where the base is floppy and dilated, and the apex is contracting very vigorously. But this is the general pattern. So it's, as I mentioned, it's predominantly a disease of women. Again, over 90% affected. However, it's relatively uncommon. It only accounts for about 1% of acute coronary syndromes. And moreover, the women who get it are generally somewhat older, almost 2 decades older than women who get SCAD. It's, again, frequently preceded by an emotional stress. And sometimes that can be an unexpectedly pleasant stress, actually, if you win the lottery. And that's called a happy heart syndrome as opposed to the broken heart syndrome. So stress in either way can precipitate an episode of Takotsubo syndrome. In men, it can be a physical stress that leads to Takotsubo syndrome, although, as I mentioned, only 10% of men get this. And generally, that stress occurs in the preceding 1 to 5 days, and then they present with this acute coronary syndrome. And like SCAD and like fibromuscular dysplasia, this is also a non-atheromatous, that is, it doesn't involve a plaque in the coronary artery. In fact, when you do an angiogram on these patients, the blood vessels look normal. You don't see a obstruction to blood flow anywhere. It's a non-inflammatory vascular disorder, but it probably involves the small microvessels in the heart rather than the large coronary arteries. And this just shows you a retrospective analysis of blood flow taken from an angiogram. And I won't go through the data in detail, but what it shows you in all arteries, the left anterior descending, the main 3 arteries, the right coronary artery and the circumflex here, that the blood flow was reduced in the patients who had Takotsubo syndrome compared to the normal controls, and they were even less blood flow occurred than in a group with what's called microvascular angina, which is another small vessel disease that can cause an acute coronary syndrome. Pathophysiology, again, poorly understood. It's been suggested it occurs due to a transient coronary occlusion that then relieves itself to coronary spasm, to, as I mentioned, microvascular dysfunction. It can also lead, as you can imagine, with that hypercontractile base of the heart to what's called left ventricular outflow obstruction. And you've got to be very careful if you give these people anything that causes the heart to work harder, that can throw them into heart failure because of that left ventricular outflow obstruction. Hormones have been suggested again, obviously because it occurs in postmenopausal women. And we know that, for example, that estrogen will modulate, it has a vasodilator effect directly, and it modulates the sympathetic nervous system, both at the level of the brain of the peripheral blood vessels, where it can suppress beta-adrenergic receptors, which have been implicated as causing, the activation of them has been implicated in causing this syndrome. And of course, when women are postmenopausal, their estrogen levels are low, and so they're probably more susceptible to getting this problem. Genetics have been looked at, and the evidence for that is pretty vague. There's very few cases. There have been some of familial clustering, but very few. And people have looked for genetic changes in a variety of candidate genes, such as beta receptors and other parts linked to the beta receptors, such as G protein coupled receptor kinases, and then an associated protein that's involved in apoptosis or death of cells. And some groups have reported polymorphisms or variants in those genes, and some have not. So the jury's still out on that. It doesn't look like genetics is going to play a major role in Takotsubo's. Catecholamine-induced cardiotoxicity is probably at this time, the major pathophysiological change that's thought to underlie Takotsubo's. And in fact, you can induce this by giving a single dose of an adrenaline-like drug called isoproterenol to a rat, and they will develop a widespread death of cells throughout the heart, and they recover from this. Over about 2 weeks, they recover from it entirely. And it's thought that the pathophysiology here is you get excessive calcium entry into the heart, and that causes contraction, necrosis, and death of the cells. And you can see here the marked infiltrate here, inflammatory infiltrate, and the death of a myocardium here. And surprisingly, that almost completely recovers. There's been a suggestion recently they don't get full recovery, but I think that paper is wanting, and most people believe they get almost complete recovery. They can, however, get complications. I'll skip over that. The pathophysiology is of interest because emotional stress of SCAD can also potentially precipitate Takotsubo's, and Takotsubo's has been postulated to cause SCAD, and they can be misdiagnosed. The big difference is that SCAD involves the heart and only that blood vessel and that part of the heart that gets blood via that blood vessel, that branch of the coronary tree, whereas Takotsubo's, of course, involves a territory of the heart that's way outside that where you get blood supply from a single branch of a coronary tree. So while the two can occur together, I think the fact that the one disease occurs almost 20 years after the other and is much less common, I'm not sure how strong that link is. It may be there in some patients. So the outcomes, as I said, generally are thought to be pretty good. However, more recently, complications have been reported in up to 50% of cases. And these complications can be quite severe and include acute heart failure, cardiogenic shock, as I mentioned, often with left ventricular outflow tract obstruction, ventricular arrhythmias, and stroke due to thrombus formation in the non-contractile apex of the heart. You can imagine if that heart's not beating properly, you can get accumulation of thrombus, of clot there, and the clot can fly off and go to the brain and cause a stroke. And the 5-year prognosis is similar to that of myocardial infarction in those people who get complications. So what I've tried to do is to try and tell you about 3 interesting diseases that by and large mainly affect women. Spontaneous coronary artery dissection, which is due to intramural hematoma, and in the ones that dissect the intima, they get a false lumen, as shown here. The fibromuscular dysplasia, where they get this beaded appearance due to this proliferation of some cell types and death of another. And then Takotsubo's, which is due to probably at least a component is increase in catecholamines, which causes then death of some cells within the heart, but interestingly it recovers in most cases. So just to summarize them here, I'll try to compare and contrast these 3 here. As I mentioned to you before, In all cases, these diseases are much more common in women than in men, in a ratio of about 9:1. The peak age of SCAD and of FMD is around about the same, around about 50 in the 50s. Takotsubo's occurs almost 2 decades later. SCAD presents with an acute coronary syndrome, a heart attack, and Takotsubo's presents like that as well, whereas fibromuscular dysplasia is more likely to present with high blood pressure because they may have a renal artery narrowing. And when you have a narrowing of the renal artery, you don't get as much blood to the kidney. The kidney then puts out a substance called renin, activates the renin-angiotensin system and puts blood pressure up. So that's how they generally present. Although if they have a lesion involving the carotid or the vertebral arteries, they can present with a stroke because they can dissect those, just like you can get a dissection of the coronary arteries. The vessels involved are the large main coronary arteries in SCAD, the renals or the carotids, as I mentioned, in fibromuscular dysplasia, and most likely the coronary microvasculature in Takotsubo's disease. Complications are a heart attack or death in SCAD, stroke more likely in fibromuscular dysplasia or hypertension for the reasons I mentioned, because of the kidney or the carotid involvement. And cardiogenic shock can be a complication of Takotsubo's, although generally the outcome is thought to be favourable. The outcome is thought to be very good for fibromuscular dysplasia, unless you are unlucky to get involvement of the carotid or vertebrals when you can get a stroke and dissection. And if you get to hospital, your prognosis for SCAD is generally good, but as I said, there's a lot of morbidity associated with the disorder for the reasons I mentioned. So look, I think I'd like to just end by thanking everyone for coming and for listening to the talk, and I want to particularly thank all our SCAD patients who have been so generous with their time and coming into this study, and they actually have a walk around the lake around Hen and Chicken Bay every year. They're called the skedaddles, and they walk, they don't run because they don't want to have another episode of SCAD, and they raise money for research. So they're a great bunch of people to work with. I also want to thank all of the doctors who've referred patients to us, including, I'm sure, a number of you here. I want to thank our team at Victor Chang, who are doing all the hard work, particularly my colleague Eleni Giannatou, who does all the bioinformatics associated with the genomics, and it's really a labour of love. David Mueller, who's head of interventional cardiology at St Vincent's, he reads all of the angiograms to make sure we are indeed looking at cases of SCAD. I also want to thank Jason Kovacic, my colleague at Mount Sinai, and I also want to thank the team here at UCID and at Prince Alfred Hospital. We're starting to work with David and Claire Arnott, and also Martin Unger at North Shore Hospital, and also Jenny Gamble, as I mentioned, has helped us with the endothelial cells and continues to help us. And finally, I want to acknowledge our support that's shown down there. So thank you very much for your time. I'm happy to take questions.
Fantastic, Bob. When I started to introduce Bob, I did say Bob is a scientist, and you didn't let me down, Bob. Thank you for highlighting the importance of heart disease in women. And, these are diseases we don't think of. We always think about thrombosis, particularly when you're at the Heart Research Institute, but this is really important, so thank you. So look, we've only got a few minutes, but if there are any burning questions, I'm sure Bob, you'd be happy to take some questions.
Well, thank you very much. That was fantastic. And when you present all three together, I wonder, have you had any thoughts about a unifying hypothesis? There are a couple of other diseases that are also much commoner in women: microvascular angina, pulmonary vascular disease, heart failure with preserved ejection fraction. Do women have as many coronary microvessels as men? Because the unifying thing could be that they have high shear stress upstream and poor microvascular reserve. So if you look at the number of microvessels in the heart of women and men, are they the same?
Yeah, look, I don't know the answer, but I do know that women with diabetes, whereas men get large coronary artery plaque disease, women get microvascular disease, and it's very hard to treat, as you already know. So they certainly, in that condition, in diabetes, are more prone to microvascular disease. I think the unifying hypothesis, I mean, the one that springs to mind obviously is the stress-induced emotion or physical exercise, the catecholamine hypothesis. What I don't quite understand about the catecholamine hypothesis is why it affects particular regions of the heart rather than the whole heart. Some people interpret beta receptor expression being different, beta 1s mainly in the base and beta 2s which are negatively inotropic in the apex. So I think that data is all based on animal data and it's not been looked at in humans. So I think that's still up in the air.
Bob, George, report. Patients with pheochromocytoma, a lot of the family, is there any relationship?
Yes, so I mean, that's a classic example of catecholamine-induced cardiomyopathy. And again, that's another reason why I'm a bit skeptical, because I don't know, I'm not aware that you might know better than I do, but I don't think pheochromocytoma causes Takotsubo's type picture. It presents with a generalized cardiomyopathy that affects the whole heart, which makes me a bit suspicious about the catecholamine hypothesis. And so what Dave's referring to is that there are people who have these, fortunately fairly rare, but they're nasty when you get them, tumours of the adrenal gland, that's the gland just above the kidney, and they make adrenaline and noradrenaline, and they can get very nasty cardiomyopathies where the heart really goes, has a lot of problems, they get acute coronary syndrome due to the excessive catecholamine release. Yes, Michael.
Oh, Bob, I'm not a cardiologist. In Takotsubo's, is there a dose response? In other words, can you, it seems to be either all or none and then you get it, but can you sort of have mild shocks and then have an increase in dilated heart? Or is it sort of some catastrophic?
I'm not aware of that, Matthew. Maybe David or David Richmond might be, I've seen that. It must be either presents with it or without it.
Great.
Yes.
So one clinical and one research question. So the clinical is, now that I see them together, those two entities are very educational for me. And particularly because you find the same variants. When you get women with SCAD, you thought of they may have a muscle dysplasia as well, to do like a CT, angiogram of their renal arteries. And this is a subclinical problem with their renal arteries or the carotids as well. That's the clinical question because of that interesting overlap. And the research one is the concept of the vessel on the dish or the endothelial cells on the dish. I really like that concept, but do you incorporate into that the factors that will elicit the genes of protein expression, or like how would you put on the dish the stressors?
Well, to answer the first question, yes, probably these women should be looked for fibromuscular dysplasia, as you will find it in a lot of them, and I said up 86% of cases. The only negative of that is you've got a young woman, and if they have recurrences, they're going to be exposed to a lot of radiation. So you've got to balance that up as to how, if you're going to do a full evaluation of their arterial tree, you need to do the internal external carotid, the cervical villus, you need to look at the renals, and you need to look at the iliacs, and that's going to take a fair bit of radiation. So if you've got someone who then presents with future episodes, and so it's a relatively young patient, you might be a little more hesitant to investigate them fully. But certainly the women who present later in life, it's useful to evaluate and see. Having said that, fibromuscular dysplasia, especially the beta type that I mentioned, is a fairly benign disease, and it usually doesn't progress. So you might find it, and then what do? What do you tell them? You get them worried actually that they have some beaded appearance of their carotid arteries, and there's not much we know of that will, if they're going to get a problem, will stop that. So you make. I'm sorry? Treat their blood pressure for sure.
Do they develop hypertension?
Well, the number of hypertension with fibromuscular dysplasia is when they have a renal lesion largely. Yeah. Sorry?
The SCAD ones.
They don't develop hypertension.
Well,
there are a percentage of SCAD women who do have high blood pressure, although as I said, compared to women with non-SCAD type coronary artery disease, they have a much lower risk of that. Now, in terms of your other question, which was using what do we do? Well, we've actually thought about that, and we're actually going to grow these cells, for example, on a high estrogen concentrations and then quickly lower it and look at them at various times after that to see whether we can manifest the difference between the patients and control, or we're going to treat them with catecholamines to try with smooth muscle cells to cause them to constrict to see whether we can manifest a phenotype that's different in the patients with control.
All right. I'm very conscious of time, and fortunately we've got Bob for a few more hours, so he will keep going all night, so don't worry. Lots of time to ask questions. So Bob, on behalf of us all, wonderful. Thank you very much for coming and delivering support. So we're now heading up to the Great Hall, and Richard, who's going to show the way?
Yes, if everyone can just head out front here, we've got some guys who will show you what the up to the Great Hall.
Thanks, Alison.
Me too.
Well done, Bob.